5, 4, 3, 2, 1. All right. Good evening, everybody. Thank you all for attending. I know there'll be some more joining on here. We're just starting a little early, so don't feel like you're late or anything. We're just getting started because usually I talk a lot and I might go over a little bit. So I did cut down the slides significantly though. So hopefully that's good news for you guys. Thank you again for taking the time to join us for our April case study. Tonight's topic, this is one that, I do read the evals, you guys, when you put in their suggested, that's why we have that in there for suggested future courses. And over the last year, I've been meaning to get to this one because this one's important regarding acute care, or AKA floor therapy, or therapy on the wards, or med-surg floors, whatever title you're using today. This has been important because I had a new saying speaking that, acute care therapy is just as important as critical care therapy. Because if you look at patients that we work hard to get out of the ICU down to either step down or to the med-surg floors, now the goal is not for them to return to the ICU, correct? Anybody have objection to that? Okay, excellent. I take it by the no reply or response that everybody agrees with me.
I completely agree.
Thank you, Darren. So, but we got to think about the opposite route. Okay. Again, sometimes we focus on the ICU and the importance of getting those patients out of there. But what about patients that start on the floor? Do we want them to get sicker and end up in step down or the ICU? And that's what we're going to talk about today. And that's why I talked, what's the difference and why it matters? Because floor therapy to me is just as important as sometimes as critical care, because these patients with significant injuries that we're going to talk about do need good old-fashioned respiratory therapy, what I call it, what we were trained to do. And we do have many devices in-house that can help them, but we just got to deliver the treatments. We got to deliver the therapy, spend those extra few minutes with these patients trying to help them take deeper breaths and cough and clear secretions, airway protection, right? So objectives for tonight. We are going to be able to recognize patients with the inability to perform sustained maximal inspiration. How many of you guys have never heard that term before? What is that? What is SMI? Should I just keep going? If I got to get some response. This is supposed to. Thank you, Stacy. Yeah, so sustained, if you guys think about it, sustained maximal inspiration. What is somebody doing with an incentive spirometer? Breathing in, inspiration, sustaining it and holding it at maximal, whatever target or goal you're telling them to hold it at. Okay, that's actual breathing technique called sustained maximal inspiration. And list other therapies available. So if they can't do an IS, do we have other devices that can help them take deep breaths? Also collaborate with the treatment team, and the treatment team includes the physicians. I know a lot of you guys have termed at CRMC, that you guys call it, I believe, the trauma protocol or the trauma special. A lot of times on second floor, but I'll explain, when I talk to those physicians, and Darren and I have both given them 2 classes on what devices and the difference between airway clearance and lung expansion. But the biggest answer I get a lot is they want us just to go see the patient and evaluate them. And they want to trust us in suggesting or recommending the best therapy for that patient based off their injuries and what they can do. And sometimes when they check the boxes is because they want RT to go there and see the patient. Even when I know it's not ordered frequently, but when you see that RT to do IS, that's important. That means specifically they want us to go train that patient, assess them, see what they can do. And if they can't do an IS appropriately, then suggest other therapies to replace that. Okay, and we use IS as our measuring device. Okay, so I want you guys to understand that's the answer I get most of the time when I discuss them. Again, I don't go tell them stop doing all this, but as to why they do it, and this is mainly why, is they trust our opinion to go assess them. And the other thing is explain, like I said, why acute care therapy is just as important as critical care by reducing ICU admits or bounce backs. So believe it or not, that is data that they track here. And if you look at the ICU patients that we discharge, either to step down or floor, within 48 hours, 80% of them return back to the ICU based off what type of complications can anyone guess? Anybody?
Respiratory.
That is correct. Whether you call it respiratory, pulmonary, breathing, it's pulmonary complications is what 80% of them return back to. So again, they go out on the floors. What's going on? If they have orders, are we seeing those patients? Are we performing those therapies? Are we doing our best to keep their lungs expanded and open and reducing atelectasis and improving alveolar ventilation? Are we doing our best to do that on the floors, or is it something out of our control and they end up in the back anyways? That's what we got to talk about and see what we're doing to make sure that we're doing these therapies so that they don't go back to the ICU. But that is data they track here. And they always question it like, okay, what's going on with these patients? And they look at individual patients. So the patient tonight that I will be talking about is one of these patients they wanted to be reviewed. So here we go. Here's our patient. And this patient, this is back in November, so it's not too far away. What, 6 months? About 6 months ago. This is a 79-year-old female. Okay, her past medical history is COPD, IDDM, DVT, and that was in the right lower extremity back in 2020. She has had a TIA and stroke, chronic kidney disease, who presented status post motor vehicle collision. She was the driver. She was trying to park her vehicle, and instead of hitting the brake, she hit the gas. I shouldn't laugh, but that is kind of funny. And she ran into a tree. So the tree was in front of her. So she went into the tree. Of course, the steering wheel was right in front of her. What do our patients do? They hit the steering wheel right into the middle of their chest. She did not lose consciousness. She was able to get out of the vehicle on her own and ambulate, but she was complaining of chest wall pain. Okay, once at the ED she arrived, she was found to have a sternal fracture. Also later found that she had isolated anterior right fourth rib fracture. EKG and troponin were unremarkable. Now remember, okay, a couple things here. Number one, she's got COPD. So, you know, her lungs aren't in the best shape. Okay, she's got some COPD going on there. Number two, she has trauma now to her sternum and her rib fracture. So what are we thinking already so far? Again, you get this call, you're the ED-RCP. What should you be thinking about when this patient's rolling in? What kind of therapies should you have in mind? Because we should be thinking the same lines as where the docs are, right? So if they walk in and say, oh, we probably need to start them on this or that. But first, we always want to make sure what they can do on the IS first. So let's look at our X-ray next. I want you to kind of thinking about those things. The critical thinking, the wheels should be spinning already. What should be ready? There's nothing, how do I say this appropriately? I don't like to wait around for the doctor to tell me what to do. Does that make sense? I should be thinking the same lines and preparing when that patient walks in, that I'm like, oh, I'm going to go get an easy PAP. She's going to need some lung expansion, I can tell you right now. Or I'm going to go get a BiPAP or whatever it is. I should already be thinking that. I don't want to sit and wait and then be told by the doctor what to do. Okay.
I mean, like anticipating and planning for what the patient needs.
Yes, absolutely. We should know this. This is our expertise. Okay. If you guys are walking around saying that airway, like the joke is, there's a code brown. We're like, whoa, we don't take care of that. We're from here up. Okay. Well, if airway breathing is your specialty, your expertise, then these are the things you need to be talking about amongst each other and sharing with the group. If you feel that because of sternum fracture with COPD, if she has COPD, what kind of meds is she on? Do we need to do her home regimen? Is she on any medications for that? What else is she doing? Is she on home O2? Right? There's a lot of past medical history that maybe wasn't listed in there that we need to find out also, if you can hear that. So listening to report and everything here. Now, if you look at her x-ray here, this is her very, very first one in the ED. The first thing you should notice is gigantic lung volumes, and she's not on any type of positive pressure. She's not intubated, okay? Anything like that. So I want you to look at the giant tidal volumes. You can see her diaphragms are almost completely flat to where you see the x-ray tech actually cut off the right diaphragm here. Her heart, though, actually surprisingly is not very enlarged because, sometimes COPD, CHF kind of go together. But remember, her troponins and EKG were unremarkable, and her heart doesn't look too enlarged. Okay. She is a little bit rotated here. You can tell because the clavicles are not lined. Her trachea is over here on this side. Again, remember she has that sternal pain. Now here's the radiologist. This is not my interpretation because I am not a radiologist, but here's what they said. They talked about mediastinal contours grossly unremarkable apart from tortuosity. Darren, I'm not saying that word right. Can you help me out? You still listening? Tortuosity. Chris, you know how to say that word right?
Tortuosity, it sounds
I'm
good.
trying to blow it up on my phone.
Tortuosity. Anybody know? Well, I guess I'm sounding it out. That's the best I know. What that means is mainly as we get older, these are general chest X-ray findings as we get older. And for example, I highlighted in red calcification of the aorta. Can anybody see that on the chest film? Is everybody on their phones or is anybody on a computer that actually can see like a full size view of the chest X-ray or zoom in on it? Everybody look at the aorta on your film. Can you see the calcification?
Yes, sir.
Kurt can see it. Thank you, Kurt. Kurt knows where to look at. Anyone else know where the aorta is on a chest film?
Kirk, are you on a computer or your phone?
I'm on my phone, but I've got my glasses on and I blew up just the film as best I could.
I think I see it.
All right, so everybody follow, you guys all see the cursor on there, hopefully. I try to make it like this highlight yellow so you can see it better. So here again, coming up out of here is the aorta, okay? What they're pointing at here is, Raul, this kind of, see this wider material here? Don't worry, I blew it up for you here so you can see
There
it.
you
So
go.
right here, as it comes out here, all this right here, I want you to look at, see, I got it all in there. So this is kind of a common finding when you look at elderly patients in X-ray, you'll see this a lot, even if they don't mention it in interpretation. It's just something that I was taught a long time ago, and it's something I always kind of look at, and you can always pick it out, seeing that you'll see this kind of striping, this wider, it'll be a much brighter, wider striping around the aorta. But again, it's just based off of age and tortuosity, whatever that, how you say that word is. But again, looking at bony structures demonstrate degenerative change, again, based off her age, because she is 79 years old. So that's our X-ray. Nothing significant about, I know, Nathan, I saw you about pulmonary contusions. Thank you for answering that, because again, when you have traumatic or thoracic trauma, right, and if you have broken ribs, if there's enough impact to break ribs, there's the potential of injuring the lung parenchyma or lung tissue underneath that, which would bruise it or cause a pulmonary contusion. So yes, I mean, there's nothing significantly showing right now, but remember, sometimes contusions or bruising show up later, not initially in the X-ray. If they do initially show it, it's a pretty bad contusion. It usually showed up pretty fast. Okay, so does everybody agree we need to at least get an IS going on this lady and see what her volumes are to do, right? Because sustained maximal inspiration is our first device, our first line of defense for lung expansion. Obviously, it's most widely common, most widely known, most widely used for patients. Again, we're trying to mimic somebody who's laying there either in pain, not ambulatory. We're trying to get them to do 10 sigh breaths. Does anyone know why we tell them to do 10 per hour?
Normal physiologic.
Because it's harder.
Every sigh or yawn per hour.
That everyone's correct. Thank you for answering. Yeah, our normal for adults is about 10 to 14 sigh breaths per hour. So has anyone ever thought about that? We're always taught like, here, do this IS 10 times every hour. Well, because we're mimicking sigh breaths. We want them to take sigh breaths. Not that you're tired of listening to me or you're giving me that big old. It's actually a normal physiologic compensatory mechanism to prevent atelectasis is what our sigh breaths. So we're trying to get them to do those. Again, trying to avoid atelectasis, improve alveolar ventilation. But a lot of times there's limitations, right? Including poor patient effort. If somebody's in severe pain, you're not going to get very good effort. Leola, thank you for answering today. I was going to think, at Fresno Heart or the open hearts, right? They've got a big wound on their sternum, right? We're talking about sternum, and we use a pillow to splint them and cough them to what? Suppress and help pain. So when we talk about pain, we'll talk about that in a little bit, but obviously that's a big important role factor, because if they're in pain, they don't want to do anything for you except give them something for the pain. Now, how do we know what the target volume is here? Do you guys just grab an IS and say, you should be able to do about 1,500? Go ahead, show me what you can do.
There's an insert inside the IS.
There is. Thank you, Leola. Anyone know what that's called?
The instructions.
Besides scratch paper or trash?
Nomogram, predicted inspiratory
Nomogram.
capacity.
There you go.
Leola, you're the bomb always.
Oh, really? So are
Wow.
you.
See, we got a good conversation going now. I love it. I heard Jane, I heard Kathy, Darren, Leola. Excellent. Yeah, so it's a nomogram. So how many of you guys honestly grab this
Not me.
chart out of the package
I
and
do.
Yep.
open it up and look at the gender and know what the patient's height and age is and
Yep.
figure out what their actual target goal is?
Yes, I
You know,
do.
because I know, thank you, Kathy, because I know a lot of people don't. And this is one of the first things with the package that gets thrown away is this package. And the reason why I'm
I
making this,
copy Leola and Kathy.
I know you do too, Jane. But I want the others to know, if you were not familiar with this, this is the actual way to set the target or goal for these patients from an inspiratory capacity standpoint. Because remember, the sustained maximal inspiration is the breathing technique, what we're having them do. The incentive spirometer is the device we have them do this technique with. And the inspiratory capacity is the volume we're measuring, okay? So there's a lot more going on here than just plastic device here, breathe on this thing for 10 times an hour. It's very important that we set it up appropriately for the patient so we know what their volumes are doing and what percent of predicted can they do. Because if they can't do at least 60% of the predicted, it's very similar to, like, think of our spinal cord injury patients, then we need to escalate care or other therapy. So our patient is 5'6", and she's 79 years old. So anybody want to tell me, if you can see on the screen, anybody want to tell me what her target goal should be? I'll slightly put my cursor, 79, that's close to 80. Yeah, 2,100 right here.
4175. 4120. Yeah. In between.
20, okay, I'll buy that, Chris. Okay, so somewhere between 2,100 and 2,150 should be our target goal, okay? Now, the reason I'm bringing this up is because here's her very first charting of her IS. Everybody see the screen? I hope so. For some reason, she has a volume goal of, I don't know where it came from. I have no idea. It's just placed in there. Is somebody wrote in there 1,000. And her very first attempt that was charted was fair technique or effort. She did 1,000, but she was only able to do 5 breaths instead of 10 with a fair breath hold. The next one, assisted by nursing, she had poor effort. She can only do 200 now at 4 breaths, 250 at 3 breaths, 750 at 5 breaths, 500 at 3 breaths, 500 at 3 breaths. Fair, poor, 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 fair. Sorry, I keep clicking buttons here, and fair. So do you guys think that she is a good candidate for IS only? Or do we need to ramp up the therapy?
No. Yes.
Ramp it up.
Yeah, so obviously if you
Trauma
guys look at
special.
these, yeah, to see, exactly. She needs trauma protocols. Yeah. So this is my beginning of this, why I want to point this out. If you guys, and I know right now, I know that most of this was nursing involved here, and RT wasn't involved right off the bat. That's kind of why I was asked to look at this case, because they want to know when we were actually involved with the case. So, but things you guys should be thinking already. If you went to assess this patient and they can't do an IS, and if you've seen that kind of poor effort, then we should start thinking about our next devices, our next therapies. So one of them we have in-house is, I know we use the Acute PAP, but in the orders it says Easy PAP. Both of them are still both the same thing, positive airway pressure. But again, they're under the lung expansion category, right? Because this patient right now needs lung expansion therapy versus airway clearance, right? We don't have any cancer signs of secretions, coughing, mucus plug, anything like that for airway clearance, but we know that we need to get her to do deep breathing and coughing to keep her airways open so she doesn't get at risk for pneumonia and other things that we mentioned. So you guys are all familiar with AccuPAP. This is something that we would escalate it up. But how would you know if the AccuPAP is working or not? How would you measure it? How would you know if you did a treatment? You just spent 15 minutes doing this therapy. You got done documenting it and you move on, right? Because your pre and post assessment says what? Did it improve or stay the same? How do you measure that change?
I do the IS before and after to see if it improved.
Excellent answer, Kent. Anyone else agree with Kent, or do they do something different?
Ask the patient.
I like Kent's answer.
Leola, I would still ask that question, make sure they feel okay or feel worse, that's a good answer. But if you think about it, how can we validate that this therapy is working for that patient? And so one way to, one way to do that. Sorry, I spoke over you.
It would be IS.
Not just IS, there's other devices out there, but IS is a quick, if it's already there at the bedside, it's a quick way to get just like think about peak flow, right? Peak flow before and after treatments. You want to have some kind of validation to say, oh, look, they can only do 500 of the IS for 4 breaths. I gave them an AccuPAP treatment for 10 or 15 minutes. We redid the IS and now they can do 1,000. Yes, that's showing that positive outcome and that positive improvement. And that's kind of what I want to talk about tonight, is what we're trying to lead to here is why this therapy, even on the floors, is important, because if you're making that positive effect on the patient, then you're going to hopefully prevent them out of our control, prevent them from going to a step down or ICU or escalated care due to pulmonary complications. So the next thing we want to look at is also PEP. We have OPEP, or the aerobica, or as Darren says, he calls it the aerobica. If you look on the screen here, here's how it's truly pronounced.
I do not call it aerobica.
I had to throw that in there.
There is no 2 E's in that word.
So the aerobica, believe it or not, is, it is, we think of sometimes as airway clearance device, but it does have a little bit of lung expansion properties. And the reason why is because we're still making that patient take a deep breath. And then as they blow through the device, depending on the resistance we set it at, creating that oscillatory PEP, it may or may not make them take a cough, but it incentivizes them to take a deep breath on inspiration before they blow through it. So another device to think about to get started is your PEP devices. So the next day, 3 days. So day 3 into this, RT was finally now ordered PEP therapy. Okay, so now this is where we get involved with this patient. So you can see PEP therapy was started. Patient's still not doing great on the IS. I mean, she's up to 750 for about 5 breaths with fair effort. Thank you to the RTs for their assistance and doing PEP therapy. Now, again, this must obviously be night shift, I'm guessing, or day shift. I don't know. I can't tell. I forgot to put the times in here. But patients sleeping, you're not going to get effective treatment if they're sleeping, because patients, believe it or not, need their rest. And what do? We wake them up every hour, tell them to get some sleep, but we'll wake you up every hour. So try to do these treatments when we can. Again, sleeping and there's something else going on here where they weren't able to give the treatment. But as I noticed going through the chart on the next documentation, I noticed we're missing a lot of this patient's treatments now. And this kind of worries me a little bit, because we started kind of late to the party, right? We didn't start lung expansion until about day 3 on her admission. And now we're probably on day 4 and we got therapy started, but we're missing a lot of treatments here. And you can see this is one shift here. The whole entire shift, she didn't get one treatment. And in the beginning of the next shift, she missed another one. So that's 4 treatments in a row was missed. And then there's 1 treatment given and then another one missed. And, this is kind of concerning to me with this treatment here, because I'm trying to figure out why. Now, I know a lot of you see a comment added here. People are picking other. Does anybody want to know what the comment says? Because I'm not pointing fingers or calling anybody out right now, but the comment for these 2 right here says triage.
Oh.
And this one doesn't say anything. And this one says triage. And, I don't know, again, the circumstances, what was going on, but again, if I try to make the importance of acute care therapy is just important, and for a lady like this with rib fractures, traumatic events, and needs lung expansion with her history of COPD and other things, to me, she kind of needs her treatments. So I don't know if she would have been the right patient to triage. I don't know if it was, like I said, I don't know if it's based off of staffing, 18,000 code blues going on at one time. Yes, that's a record. That's happened before. And 27 rapid responses at one time.
But also usually triage, I mean, you may skip this patient this time, but you'll catch that one that next time and miss a different patient. So it's not always the same patient every time.
That's an excellent point, Kent. And again, I don't have the answer to tell you guys why, except this is what was documented in the chart. So let's move on. And
At one time, treatments were triaged because it didn't have medication associated with it. So then people would just go ahead and skip it. And then I think there's another part where people wonder how effective EasyPap is, especially, I mean, if you go do an EasyPap sometimes, patients will only do it for maybe 5 minutes if you're lucky. And so I think people just see it as, it doesn't really do any good anyway. Not saying it's right. I'm just saying that's probably.
No, it's a great point, Kathy. And again, well, it wasn't EasyPap. This one was for PEP, and I don't believe there was treatments ordered yet. But again, based off her IS performance, to me, again, thinking to myself, she kind of needs her treatment. So again, I'm not questioning. I want to move on because I'm going to run out of time if we talk about this. But I want you guys to consider this: is think about, are you triaging the right patients? Kent made a good comment. Maybe you missed it as a first round, but the second round, maybe you still at least go see that patient and make sure, at least write a note or say something based off of that. The other thing, well, we'll talk about this later about that. Let's move on. Now, the other thing that the physicians wanted was this patient to get up out of bed, right? To ambulate and get up out of bed. And again, based off of her pain, it wasn't being controlled appropriately. Well, I shouldn't say appropriately. Her pain control wasn't adequate in her view to where she didn't feel comfortable either taking deep breaths. She didn't want to get up out of bed, move around, or walk around. So again, that feedback was given back to the doctors, and the surgeon came in and actually did a rib block for her, right? So they actually did this rib block where they went in and with ultrasound, it's basically ultrasound guided, and then they go in guided with the needle and they go directly into the nerve and inject, I'm not sure exactly what medication, something cane probably, right? Something numbing to numb the nerve, and basically that. So I'm thinking, okay, this will help us because now we can get maybe a little more aggressive with her on taking deep breaths because we can get her pain controlled a little bit easier. Someone coming off mute, want to talk to me? Sorry, it's hard for me to read the comments at the same time as give this. So, okay, so after admission, again, I want to continue on here. So here's kind of like, I won't call it this point, but again, ongoing oxygen demand, difficulty mobilizing due to pain. Okay, so they did the nerve block, but now she's starting to have, so let's see, she's 11, so 6 days in. Now she's starting to desat down to 75% on 3 liters. Her oxygen demand's going up, and her situation is changing. And again, this is the things that I call the turning points that we should be recognizing this, that again, I'm not going to blame the missed treatments, but that could be associated with it, that we missed quite a few treatments on her. We didn't get her doing her lung exercises, volumes. And of course, on night shift, right? Night shift, where's my night shift people? It always happens on night, right? About 11:30, RTs are called to the bedside. She's desatting. Now there was treatments given. She was having her PEP given. They had a dual-neb treatment given. 1 o'clock, again, patient began to desat. So that's 11, only 2 hours later, she's desatting again. O2 increased to 4 liters, back to 99 sat. We'll try to wean off through the night. Then 6 a.m., she was still holding at 92% on 4 liters. We'll pass over to day shift. But again, this is what we're kind of looking at here. The 79-year-old COPD, rib sternum fractures, minimal activity, secondary to pain. She's not getting up ambulating, just laying there in bed. You know, what else we need to start thinking about doing? So after this, of course, they rounded and met with her. They figured we need to escalate care. So up here, you can see on the date from the 18th, she was transferred to 4 East, or a step down CPCU. This is where her first blood gas was drawn, and you can see that she's going into respiratory failure. Her pH, if you guys can't read it, I'll read it out to you. It's 7.34, CO2 is 54. Her PO2 is 59 on those 4 liters, satting 87%. So once she was placed into 4 East, She wasn't placed on high flow yet, but her oxygenation was increased. I cut it off right here, but I think this is 6 liters. It went from 4 liters to 6 liters. Again, here's her sats. We're holding there, good mid 90s. And then again here, she had another episode on the end of the 19th at this night. They drew another gas. Her PO2 has significantly climbed, but her CO2 is still 51 with a pH of 731. That was on 100%. Now here we go so she spent not even a whole day on step down, and now she's going to get transferred to the ICU. So she was admitted to ICU on 11/20, so that's 9 days after admission. She had a gas drawn in the ICU, 733, 53. PO2's back down to 63 on 40%, so that's 89. She had originally this one here, so she was ordered high flow now. So now she's on high flow, and you can see here that she was on 45, 50, 45, that percent. Where's did I cut out the flow? I believe she was on 40 liters of flow. Oh, it's right there. I think I cut it off. It looks like 30. Apologize for that, cutting it off.
Wait, I have a question.
Yes, ma'am.
Sorry. So this lady's 79 years old, and they get tired out very quickly. So how long would you do the easy PAP and PEP therapy or Arabica treatment? Would you say 5 minutes and 5 minutes? Or is there a time frame that you would do it in to not tire them out but get optimal care or treatment?
That's a great question, Leola, and it kind of reminds me how we used to do IPPB is the way I look at it. Okay. So with IPPB, I know we don't use it anymore, but for those of you who've never used it before, what we did is when someone can't do, and again, easy PAP is what replaced IPPB. Okay, that's what we have to replace it. What we would do is when you do that IS measurement and you know that it's okay, they need a little extra right? A little positive pressure to take a deeper breath. So I think you'd have to gauge off what pressure they're tolerable. I mean the AccuPAP makes it easy where you can adjust the little PEEP valve, right? So you can start her on 5, see how many breaths you can do. They do recommend it will tire patients out, so you can give them rest or break in between. You know, if they can only do 5 minutes or 20 breaths or 10 breaths, you might want to give them a break and rest after that. But again, that's why it's important to measure the post-treatment to see if it's actually working. Because if it's not working, then maybe we need to contact the physician and say, we've been doing easy PAP with IS or PEP the last 2 days or 24 hours, 48 hours. It doesn't seem to be helping her. We may need to escalate to something else that we'll talk about other devices, but we need to escalate. I don't want to spoil it because she's going to go that way. So I'll just keep going, Leola. Hope I'm answering your question, but gauge it off patient effort. If they get tired, you can give them breaks, right? You don't have to push them for 10, 15 minutes straight with the easy PAP. If they need to catch their breath and take a break, absolutely let them do that because you don't want to tire them out and make them go backwards. Okay. Now looking at her. Sorry, go ahead.
I say I always like at least 10 minutes at least anyway. I mean, they feel tired. Well, come on, a little bit more. Give me 20 more breaths. I mean, just something that make them go a little bit longer and a little more benefit, you know?
It's patient tolerance, right? So, I mean, every individual patient's going to be different, right? You'll have to just kind of gauge your therapy and just see what they can tolerate. Maybe the first time you see them, they can only do 5 minutes and say, hey, you know what, next round when I come back, let's shoot for 10 minutes next time. And, you know, again, this therapy, I know if you guys heard me say it earlier, I make fun of this word, but we want to incentivize them, right? We need to give them some kind of goal and ambition to reach this target. By doing that, you want to get them involved to do this because we can't do it by ourselves. We need their participation and involvement. And now that we have pain control under place, you know, there should be able to push these patients a little bit harder. Now on the screen now, you're going to see their x-rays. So again, this was a day 1, okay? But what I want you to notice here on day 7, when she's going into the ICU, is you can see the right lower lobe. How do I know it's the right lower lobe? Because I can see the right heart border, which shares the right middle lobe, which is anterior. So I know this is posterior. Okay, so this is right lower lobe. And I'm not sure if it's atelectasis. I'm not sure if it's effusion or fluid, but we know there's something changing in this right lower lobe and having issues right here is what could be causing the problems. Okay, so when she's in ICU, again, her IS results here were charted. She's doing about 5 breaths, 750 here. Oh, by the way, look, her target's been moved up to 1500. Someone moved it up. Still not very good effort. And I don't know if that's due to pain or she's weak or atrophied. Maybe her muscles are atrophied. But again, here's PEP and there's IPV. And again, in my opinion, for someone like this who's kind of declining in status and now moved to the ICU, I would probably pick IPV because that's ordered now for her. I would probably pick IPV as a little more aggressive treatment for this patient over PEP. And this is kind of something that I want to discuss with you, because if you have, I know if you have both orders, it's confusing, number one, but two, we can contact the physicians to get those changed. Because if IPV is going to accomplish the same therapy or benefit for the patient than PEP, then why don't we ask to get PEP DC'd and we'll continue IPV therapy. But when you guys have a choice of two different therapies, I'm just curious of when or why or how you choose one or the other, and why. Because in my mind, I'm looking at this patient as she's declining. She went from floors to step down to now ICU. I'm probably going to go with the more aggressive treatment, which would be IPV, and now spend a good 10, 15 minutes coaching her on either using a mouthpiece or full mask to give her treatment. And that's why I'm asking this question, because this comment here, what it says is the RT chose to do PEP therapy instead of IPV therapy. And then the next round was IPV. And then again, when it says not given, it's because they did IPV. So I see this go back and forth. And another question I have is, are the RTs communicating the plan of care between shifts? That's something to think about here, because again, if I'm giving a report on this patient and I'm like, hey, we have PEP ordered an IPV, but I gave her IPV all day or all night, whatever shift you're on, because that seems to benefit her better. That makes her take deeper breaths. That makes her cough. I get a better IS result. Whatever your determinants are, handing off that important information about the care, the plan of care, is what's important here. And if you're on day shift and you're rounding, you have to be with the physicians. You again fill them in. What's working best for the patient? And if IPV is harmful for her and she's complaining about it and not wanting to do it, then again, we need to address these with the physicians to ask them for better care. Now, she was on high flow also between the IPV therapies. And I thought a lot of people asked, does high flow have any lung expansion benefits? Does anybody have the answer to that question?
Little, some. Yeah. I mean, it's unmeasurable, but it varies on their breath.
Yes, it does.
Excellent, Kent. Thank you, Chris. Yeah, so remember, it does create a little bit of positive expiratory pressure, right, based off how many liters of flow. Like Kent said, we can't measure it. We have no idea. The best data out there that we have based off of bench testing is for about every 10 liters of flow creates about 1 centimeter water pressure. So maximum optiflow is 50. So the max really you're going to get 5. But if we're doing our pulmonary hygiene treatments, our lung expansion treatments, along with high flow, that might help sustain recruitment of what we're doing. So I just wanted to bring that up and make that a point that, high flow is not the worst thing that we can have here. So again, by overcoming that labored breathing, right, with the positive pressure in the alveoli, that difference between those actually can cause some of that, either PEP or PEEP, whichever way you want to call it. And just for fun, everyone that's watching the screen right now, I thought this was interesting research in some of this, is I never realized that I found this picture online, and this is a Optiflow Junior cannula on a dog, which looks like a beagle, because he looks like my dog, a beagle. And I didn't even know they used high flow in the veterinary. Anyone else know this? Anyone else ever seen this before?
No.
Yeah, I've actually never seen this before. I ran across this. Hey, here's a trivia question. Optiflow Junior cannula is green one. So what's the max flow on the green one? Anyone know the answer to that? Any pediatric or neonatal specialists want to answer that one? Besides Chris? Okay. All right, we're moving on. They don't like my picture of my doggy.
I have a question about like the mucus production. Has it been stable the whole time, or is anything changing with that? We have
Excellent
a COPD
question.
patient.
Yeah, and according to, again, I don't have screenshots of the assessment, but I can tell you that her cough was weak throughout the time and minimal secretion. She wasn't coughing anything up. But good question, Nathan, to consider, because yeah, when that starts happening, then maybe we need to consider. Well, again, we have IPV going now, so would you agree or disagree that IPV will cover lung expansion and airway clearance if needed? My answer is it's going to take care of both right now, and that's what we're doing. But yeah, she was not producing anything at the time, Nathan. Okay, so another quick snapshot. Now, she spent 3 days. So here's five North ICUs where she was at. She spent 3 days up in the ICU, again, maintained on high flow, getting her IPV treatments. You can see a very nice decline in FiO2. So you can see at the end of her day in ICU, we were able to wean her down on high flow, 35 liters, 35%. And now she's going to get transferred out to 9 West step down. So first of all, thank you everyone who took care of this patient, because she never got intubated, right? Because isn't that something that we were all thinking? We were all thinking that she went to the ICU for intubation watch, intubation observation, whatever you want to call it. But again, because of our aggressive therapy and keeping her lungs open and working properly, I think that had a big deal with her not allowing her to even going on BiPAP. She wasn't even placed on non-invasive ventilation either at the time. She stayed on high flow, and we were aggressive with the IPV treatments. Now here's her x-ray before she left the ICU. And again, take notice of the right lower lobe, but now it's beginning to look a lot more like a fusion. Okay, so if you read the interpretation from the radiologist, it's right pleural fusion is what they're diagnosing it now, not so much as consolidation or infiltrates, but actually a fusion, because of cosophrenic angles. Now you really can't see them, they're blunted, and she's pretty much laying on her back, so it's posterior in the back there. Again, so remember her current therapies that were ordered. She had PEP ordered, she had IPV ordered, and again, we still have IS ordered, and that's our thing. But again, I want to make another one. Here's another screenshot of her therapies in there that she's still doing rather poor on her IS. And again, here's this kind of like chose to do PEP instead of IPV. And I would kind of question that. Again, if I'm in the ICU, there's a reason why this patient's in the ICU. It's kind of like when we talked about the spinal cord injury patient, right? If a patient's laying there in spinal cord precautions on a cannula, 4 liters set 92 with paradoxical breathing, and based off a C6 injury from whatever injury, traumatic injury, again, that's that patient you don't want to walk by and say, oh, he's just on a cannula, don't worry about it. If this patient's brought to the ICU, there's a reason why she's declining in status. And this is where we need to jump in, put our RT capes on and get in there and perform good old fashioned respiratory therapy and prevent them from being intubated. Has anyone ever experienced that? Have you guys got to be involved with patient care where the docs want to move them somewhere because they want to intubate, and you say, hold on, no, let's do this, and this first, and I don't want to get her intubated, and you actually were successful and the patient's never got intubated? Has anyone ever got to experience that before?
Yeah, many times. That's good stuff.
Yes.
And how did that feel? I mean, didn't you feel like you accomplished your job? I mean, that's what we are as RTs, right? Respiratory therapists. And we go in there doing our procedures. And again, it's acute care. I know it's not the most exciting stuff, but it's just as important as critical care from preventing these patients from being intubated. I know it happens several times. I've done it several times, and there's nothing better to come in the next day and find that person out of the ICU, on the floor, on a cannula, whatever we did, and never got intubated. So it's a great feeling. And I hope that if you haven't experienced that in your career, that you do, and then you kind of have a more appreciation for that feeling of what we do in our profession is what we do is our specializing in these special breathing techniques that we do. But again, just kind of question this, if you got a patient in the ICU, which one's going to be the more effective therapy to move on? And again, this is kind of what I just made a comment here is, are the RTVs communicating the treatment plan? So again, here's another, okay, here's PEP not given, and then IPV, that's the high flow, then IPV, then back to PEP and not IPV, and then IPV. So it's I was kind of just curious of why, whether someone wants to speak up or not, or you guys want to talk to me in private or something. I'm just kind of curious of why are we choosing which one we feel is the best? Are we choosing the best one for the patient? Just keep that in mind. Kind of think about that next time you have something like in the situation, because I'm sure you're going to see this type of patient many, many more times in your career. So again, looking at her x-rays as she was taken out of the ICU, this one on the left is that one that we're kind of like, she is rotated. I know the left lung looks a lot larger, but she's not overall hyperinflated with all the device. It's just she's rotated. You can see her trachea is over here. and shifted over here, but it's not a good picture of her left lung. But again, you can kind of still see that haziness. And if you look at the next x-ray, let me see when this was on the right, that, yeah, an impression is now that you see the loculation here, this is an actual right pleural effusion that's sitting down here in a right lower lobe base here. Okay. And again, no matter how much we try IPV, PEP therapy, whatever we want to do, we can't really resolve pleural effusion. So of course, what she needs is she needs to have a needle thoracoscopy, which she did. Again, talking about the trauma protocol. For those of you not familiar with it, what happens sometimes here at CRMC is that patients, when they're admitted to the floor, the admitting physicians and the ED kind of check everything off under the respiratory. So they check off CPT, PEP, IPV, CPT with the vest. They almost check everything that we do. And again, when I talk to them, there's a reason why, is they want us to go see them and evaluate the patient. And if we feel that one is better than the other, to communicate that back to them. How much time? Okay, 15 minutes. Okay, we're right on time here. Okay, so let me catch you up here. So she spent those 3 days in the ICU. She was transferred to 9 West step down now. She's still receiving high flow. 2 days later, she got her right thoracentesis, so they were able to evacuate that fluid. 11/26 though, she was still, I don't know if it was pain from the thoracentesis, but she was having some issues where they had her placed on non-invasive. So this is the first time she was placed on non-invasive. 12/5, nothing significant, right? Just a little assistance. It says per ABG, and I guess I forgot to put in the ABG here. I apologize, you guys. We'll have to look that up in a sec. Okay, so she tolerated through the day shift. What was interesting is at night, she ended up vomiting. That's always one of our scary feelings, right? When somebody's on BiPAP, thank goodness she wasn't restrained or anything. So she's able to have the mask removed, her airway was suctioned out, and she was returned back to high flow. 2 days later, she got a repeat CT. Her right pleural effusion was improving. 2 days later, she was weaned to room air from high flow. And then 3 days later, you know, she had an increasing white count. And this is always what's scary, because now we think, oh, we did all this hard work to prevent pneumonia. What kind of infection is she getting? But she actually ended up with, and her effusion was not infected. It was actually a UTI is what was happening for her with urinary and respiratory infections, which I didn't see any respiratory infections on the lab. I don't know what that's written there. Now, even though she's out on step down, we still had PEP and IPV ordered for her. So again, we want to continue the therapy, but we're kind of back to a theme here where now I guess, again, according to the charting, patient or families refusing multiple times here. You can see from the charting. Here, they were able to do one treatment, but again, not given. And again, this is multiple times here looking at that. So I don't want to, I'm not calling out the documentation, but I want to make a point here. Why is, okay, we got her not intubated, we got her out of the ICU, she's back down to step down, but now we have a pattern again where we're missing treatments again. And again, if we miss too many or something could potentially happen, she could wind back up in ICU. So again, our job is to prevent that from happening. So again, she still has diminished breath sounds in the right lower lobe due to her pleural effusion. Now she's taken to IR, and they actually chose to put a chest tube in her for pleural effusion drainage. Her IS has improved. She's actually doing around a liter now. She's in no respiratory acute distress. So some of this could now have been from the fluid that they took off. She's only weaned down to, she's still on the nasal cannula, not from room air. But again, the orders were still to continue easy PAP, PEP, and doing treatments. So you can see here, she's actually discharged on the 15th. So I can show you her last, here's her last 3 days in the hospital. Looking at her, look, the goal has actually been changed to appropriate now. Oh, it got moved here though. But 2000 doing 1250, she's actually doing good effort. She's doing 10 breaths. 5 breaths here, not sure what happened there. But again, we're missing the treatments, the PEPs. This is the time when, you know, if you know that discharge is coming or she's going, you know, this is the time if family is at the bedside or refusing, that maybe it's time to educate the family on the aerobica, I'm sure is what we were using for the PEP therapy. Again, remember, these patients can take those devices home with them, instruct them how to clean them. They can put them into the dishwasher. You know, make sure if you're there close to the time when they're discharged, that you can actually do that for them to benefit them and say, hey, you know, when you're sitting there, you know, continue to exercise your lungs. So on her discharge, again, she was discharged to a skilled nursing facility, so she couldn't go home because there was nobody to take care of her. Based off her COPD, again, they wanted to continue. They still write this, it still cracks me up. Pulmonary hypertension, again, continue her to get out of bed, be ambulatory, get her back on. So see, this is the first I found that she's actually, I guess, back. Either they're starting this for the first, but they're starting her on Spiriva and Advair, I guess, to control her COPD and keeping her SATs above that. Now, the last couple of minutes, I want to discuss some of the opportunities that I feel, and you guys can chime in anything you want. I've mentioned several times that the trauma protocol is ordered. When I talk to the physicians about it, that all these devices do the same thing, can we just pick one? Their main answer usually is, hey, I just want to get RT at the bedside to look at the patient and let me know what's best for them. Because again, they're looking at us as the experts to assess the patient, evaluate the patient, and recommend the best therapy. It's kind of like on day one, you guys were all taught how to communicate a physician with SBAR, right? So situation, background, assessment, recommendation, that's what they're asking for. Get back to me on what you think's best for the patient. Please let me know if communication is not happening between shifts in the plan of care. Again, that's why when we go to notes and plan of care, instead of just oxygen progressing, write a quick note in there. Is it progressing or not progressing, and why? What's going on? But make sure you guys are communicating this kind of stuff back and forth to each other. If you have 2 treatments ordered and one you feel is working better than the other, then pass that on in the handoff and let the next shift know. Because if not, then you kind of see charting like here, what I kind of highlighted again. Again, not given, triage, then one's given, and then not again, and not again, and not again, and then another one. And it's very inconsistent therapy. And I know the physicians can't see this and look at this, but if they were to see something like this, I'm sure they would question this. What's going on here? Why are we missing so many treatments? Again, following orders. So again, and by the way, selecting the reason and other in triage is not appropriate. So if any of you are out there doing that right now, I would suggest to stop doing that and actually pick an actual reason why the treatment was missed. If for some reason that shift that the supervisor or the manager has declared a triage, what would you call that? A triage event during that shift. Okay, that's different, but I don't remember us actually ever doing that per policy. You guys, we do have a triage policy if you want to read it and look at it. But again, don't just, if you're missing the treatment because you're busy, write one of the other reasons in there. Don't write triage in there, again, because that's not an appropriate answer to do that. Oh, and the other one, what did I say? Oh yeah, the documentation. So make sure you're doing the plan. So again, airway clearance, again, in lung expansion are vital tools. Like I mentioned earlier, that acute care is just as important as critical care. And these patients are in there and they order these therapies. This is what we were trained to do. And we can do it very effectively to either mobilize secretions, expand their lungs, prevent atelectasis. By doing all this, we improve gas exchange. We hopefully prevent infections like pneumonias from happening. And decrease hospital length of stay is a big deal right now. They're monitoring that and looking at that right now. So the faster we can take care of these patients and not escalate them to other units is much appreciated. All patients are going to be different, so don't use the same device for everybody. They're all different based off their situations. And just remember, be proactive. Again, if you're there at the bedside assessing the patient and you feel that another treatment is better for the patient than what's ordered, then please notify someone, contact somebody. Let them know that, hey, I feel this patient would benefit from easy PAP versus PEP therapy, or vice versa, whichever it is. But we got to communicate a little bit better. And again, as us as the experts, our physicians rely on us for our expert opinion to come up with a better plan someday with the physicians. Okay, I left you guys with 7 minutes with questions. That's all I have for you to now. Anybody have any questions, comments, concerns? Nice things
Did you
to
say atrophied earlier?
Absolutely. I said her muscles may have been atrophied and you need to incentivize her to do the IS appropriately.
With an aerobica.
That is correct.
Aerobica.
ARROWBEEKA. Aerobica.